Good morning. I am Dr. Teke Apalata, a clinical microbiologist. In the second part of this lecture on sepsis and septic shock, we are now going to discuss the pathogenesis and the management. So let me just share my screen with you. All right. So this is our second lecture on bacterial sepsis and septic shock. And in this part 2, we will mainly focus on the pathogenesis and early goal-directed therapy. I am Dr. Teke Apalata, a consultant in clinical microbiology. So, the pathogenesis of sepsis, how this happens, to try to understand this, you need to know two things. So on one side, we have the host immune cells. We have the host immune cells on one side, and on the other side, we have the microbes or the microorganism. So the host immune cells have what we call pattern recognition receptors. And the pathogens have what we call pathogen-associated molecular patterns. So the pumps. So the bacteria have what we call the pumps, and our phagocytic cells or host immune cells have what we call the PRR, or pattern recognition receptors. We have, there are 3 families of PRR that our host immune cells have, but the most commonly studied are what we call the toll-like receptors. Like our gram-positive bacteria, if you are infected with a gram-positive bacteria, your gram-positive bacteria will bind to the toll-like receptor 2 of your host immune cells. But your gram-negative bacteria will bind to the toll-like receptor 4 of your host immune cells. So that is the reason why the response will be different, whether you are infected with a gram-positive or a gram-negative. The response will be different. The type of cytokines that will be released and the other mediators that will be released will be different because they bind, gram-positive and gram-negative bind into different types of receptors with the host immune cells. So before binding, there should be recognition. Now what happened is that here we have a microorganism. So you are infected with a microorganism. Those microorganisms need first to be recognized by your phagocytic cells. And the first line of phagocytic cells can be the neutrophils and also your macrophages. Now you will see that all these phagocytic cells will have your mannose receptors, the MAC1 receptor, and the scavengers receptors in your neutrophils. The macrophages also have those 3, but in addition to that, they have the CD14 and they have the toll-like receptors. And as I said, we have commonly 2 types of those toll-like receptors, the toll-like receptors 2 that bind to your gram-positive. If those pathogens are gram-positive, they will bind to the toll-like receptor 2. But if those pathogens are gram-negative, they will bind to the toll-like receptor 4. So what does it mean is that there is a selective specificity for microbial patterns. That's what we call selective specificity for microbial pattern. Then, in addition to what we have said, is that your PRR can also recognize something else in addition to the pumps that you find in the microorganism. So microorganisms, after invading the body, can release other molecules, what we call molecular patterns or danger-associated molecular patterns that we call the dumps. So your immune cells can also recognize the dumps, and then there will be response. So what I'm trying to say is that when you are invaded, your body is invaded with a microorganism or pathogenic bacteria, they will release the dumps. And your immune cells, the host immune cells, will recognize those signals. They will recognize that. Now, there will be a cascade of responses. They might attract at the site of infection rapidly the innate immune cells. That can be your neutrophils or they can be your macrophages will be attracted. Then those immune cells will release a number of cytokines that will attract the second line of immune cells that are the lymphocytes that will be attracted at the site of infections. Or the other thing that can be happening is that there will be activation of the complement system. The complement system can be activated and the complement fraction can come at the site of infection and they can be able to kill the pathogen. So the complement fraction are able themselves to kill the microorganism, or those innate cells and also lymphocytes that can be attracted are also able to destroy the pathogen. And you will have other cascade of events from the activation of the complement system will lead to the activation of the coagulation system. And this patient can progress toward DIC. And you will also have the release of other pro-inflammatory mediators, and this will lead to apoptotic cells, that is a programmed cell death, and the patient will then develop immunodeficiency or immunosuppression as a result of the infection, and he will progress towards septic shock. So now let's look at how the complement system is activated. Now this is your microorganism, this is a bacterium that invade your body. Now, how does the complement system is activated? You have a different fraction of the complement that will be attracted at the site of infection. Here you have the C3, you have the C5, you have the C7, 8, and 9. So they are all activated. Now they are approaching the microorganism. So the C3 will come first, attach to the bacteria at a specific complement receptor. Then it will break into fraction, what we call the C3A and the C3B. So the C3A will remain attached to the complement receptors on the bacterium. Then from there, the C5 will approach and attach to the C3B. Then it will also divide in 2 fractions. And so then you have the rest, the C3, 8, and 9, they will attach. So together they will form what we call a membrane attack complex, what we call MAC or membrane attack complex. And this will then be able to destroy the bacterium. So there is cell death. Okay, so that is how the complement system works. So the infection is gone. The other way of killing microorganisms is through phagocytic cell destruction. So your phagocytic cells, like your neutrophils or your macrophages, can destroy the bacteria. So we have neutrophils and macrophages. The first step is what we call opsonization. So opsonization will happen. Opsonization happen like this. You have a microorganism and you have antibodies that will attach to this microorganism. So they are preparing this microorganism to make it highly susceptible of being phagocytized, by the phagocytic cells. So this is the process that we call opsonization. So it's preparing the microorganism from a phagocytic activity. Then after opsonization, this is the phagocytic cell that is approaching, and it will then attach to the antibody. So you will see that the phagocytic cells has 2 receptors. You will see here, this is the antibody receptors, this is the complement receptors. So here it will attach to the antibody that was already attached to the bacteria. Then from there, here, there you have a complement receptors, that here you have a FC receptors that attach to the antibody, and it will then be able to phagocyte the microorganism. So after binding, the bacterium is taken into the cytoplasm, and the membrane vacuole containing the phagocytosed bacteria is known as the phagosome. Then there will be a number of processes like fusion of the phagosome, cytoplasmic granule, you know, what we call specific granule and azirophilic granules will be released. And you will have another process to destroy the bacteria is what we call the release of reactive oxygen intermediates that are produced through the NADPH activity, you know, NADPH oxidase activity. So this is what we see here. So the microorganism, you know, is then taken into the cytoplasm of the phagocytic cells. You know, it is taken, so the pathogens are there. You have the antibodies that are attaching here, or you have the complement if there is a complement activation system. Then, your phagocytic cells will release specific granules, and azirophilic granules will be released will be attached to, will be in contact with the phagocytosed microorganism. And you will also have what we call the NADPH oxidase, you know, with the release of reactive oxygen intermediates. So those are then very toxic to the microorganism, and they will then destroy the microorganism. So this is how it happened. Now, another thing that will happen is what we call the CTL activity. So the CTL activity is mainly made if the microorganism was an intracellular microorganism. So what we have seen is if the pathogen is the extracellular pathogen, but the CTL activity takes place when you are dealing with, when you are infected with an intracellular microorganism, you know. So this is your cell that is invaded by the bacteria, and here you have an intracellular bacteria. That intracellular bacteria can be either an obligate intracellular pathogen for it to be really killed, or if it's a facultative, it can escape the process. So if it's an obligate intracellular pathogen, then you have the CTL activity. This is the antigen. So these cells will present the antigen there so that it is recognized by your T cells. Then you have the antigen receptor. So your T cells will then come. It will then bind to the antigen, you know, where there is antigen presenting cells. Then from there, it will form what we call a perforin complex that will enter to destroy the bacteria intracellularly. So intracellularly, you need a perforin complex to kill the bacteria, and the microorganism are destroyed. You know, the microbes dies. But if the bacteria is a facultative intracellular pathogen, it's not an obligate, even if there is the activity of the T cells, you know, the CTL activity, it's attached, it creates a porphyrin complex, it enters, it destroys the cells. After destroying the cells, you know, because this is a facultative intracellular bacteria, it can still survive outside the cell. So it will still replicate. Now, after understanding what happens, then after being able to suspect that your patient has an infection, and you ask yourself, could this really be sepsis? Now remember that you use SOFA criteria to make the definition, to make the diagnosis of sepsis in the presence of an infection. So you establish that there is an organ dysfunction. You look at respiratory markers, you look at coagulation factors, you look at cardiovascular markers, by measuring the mean arterial pressure, and you look at the liver dysfunction, or for the level of bilirubins. So you look at all different markers. In the presence of an infection, you make the definition of sepsis. So if after identifying that the patient is indeed diagnosed with sepsis, there are two things that you need to do. One is resuscitation. Fluid. You have to give fluid, mainly the normal cell line, to this patient. And the other thing that you do at the same time is to try to control the source of infection by doing source identification, whether it's a chest infection, or it is a urinary tract infection, or it is a abdominal infection, or it is a soft tissue infection. So you need to do a source identification in order to do a targeted therapy. So to know what specific antibiotics you are going to give to this patient, And if the patient is not able to keep up the mean arterial pressure despite adequate resuscitation, then you need to put this patient on vasopressors. You can give norepinephrine or dopamine, or you can give the alpha and beta agonist to this patient. And you have to measure the oxygen saturation. If the oxygen saturation is below 70, check the hemoglobin level. If the hemoglobin level is below 10, transfuse the patient. But if the hemoglobin level is above 10, then correct the cardiac output by giving dobutamine to the patient, that is a beta agonist. You start with an alpha agonist, but here you will require to give a beta agonist. So in conclusion, I also spoke about source control, that the commonest causes, I say that source of infection can be respiratory or abdominal infection. So what is the early goal-directed therapy in patients with septic shock? The early goal-directed therapy means that within the 6 hours of presentation of the patient who is suspected of having septic shock, you need to achieve the following, by looking at the 5 parameters. So CVP, you need to achieve 8 to 12. Mean arterial pressure should be restored to between 65 to 90. Urine output should be above 0.5 mL per kilogram per hour. Mixed venous oxygen saturation should be above 65%, or saturation of oxygen above 70%, and hematocrit level should be above 30%. So those are your goal, the goals for your therapy. So you are monitoring those 5 things by doing your source control and by resuscitating the patient, by giving vasopressors. You are trying to achieve those 5 things, but you are looking after those 5 parameters. Okay, so you do that, you reduce the work of breathing by putting the patient on mechanical ventilation. You do fluid resuscitation, you use vasoactive agents, and you transfuse the patient. So those are the 4 interventions you do to achieve those 5 parameters within your goal-directed therapy. So in conclusion, what you do within the 6 hours of identifying of your septic shock, I say don't use the word severe sepsis, of your septic shock, you measure the serum lactate, to confirm if the serum lactate is above 2 millimole per liter, remember, it's septic shock. Or beside the serum lactate, your patient should be on vasopressors to have their mean arterial pressure maintained from above 6 or from 65 and above. You know, so you measure the serum lactate, you obtain blood culture need to be obtained prior to the antibiotic administration. Then you administer the patient on empirical broad spectrum antibiotic. If the patient is still hypotensive and the serum lactate is above 4, what do? You deliver an initial minimum of 20 milliliter per kilogram of crystalloid or equivalent. Then you put the patient on vasopressors. Now, in the event of persistent hypotension, despite fluid resuscitation and lactate level of above 4, what you do, you need to achieve a central venous pressure of above 8, and you need to achieve a central venous oxygen saturation of above 70%. Now, what can you complete in the next 24 hours is that you start administering low dose of steroid for trying to control septic shock. And you can also administer activated protein C. And you need to maintain adequate glycemic control, and you have to maintain a median inspiratory plateau pressure of below 30 centimeters, you know, for mechanically ventilated patients. So this is, in this part 2, we try to understand the pathogenesis of septic shock and sepsis, and we also discuss early goal directed therapy. So in part 1, we discussed the definition. If you did not check our part 1, go and check where we discussed the definition of sepsis, septic shock, and organ dysfunction. And we also discussed the pathogen. We also discussed the causative pathogens of sepsis. Now, in this part 2, we then discuss the pathogenesis and the management of sepsis and septic shock. Thank you.